Great, welcome everybody. Good morning, good evening, good day, depending where you are in the world. This is a fantastic opportunity for us to get together and discuss what have we been learning and what we still need to do in order to understand much better the situation with regards post-acute care and rehabilitation during the COVID-19 pandemic. This is an international webinar, a symposium between people from China, the US, and Europe. And we're going to be discussing the clinical evidence and guidelines for post-acute care and rehabilitation for COVID-19 patients. We're going to be discussing post-acute care policy design and implementation, and challenges and lessons learned during about healthcare systems around the world. Now, the COVID pandemic has brought a lot of attention to particularly the care of older people in Europe, North America. We've had the experience of huge numbers of deaths of people living in post-acute care settings, and we have a lot to learn. We've also understood that this hasn't been the situation all over the world, and we also know that we need to be prepared for the next potential waves we might have and make sure we can have much better responses. So I am delighted to be part of this symposium and delighted to moderate, and I'm really looking forward to learn from all our speakers. Thank you very much.
好，谢谢阿德琳达。阿德琳达是伦敦政治经济学院卫生政策系护理政策评估中心的主任。那下面我们请厉建安院士来给我们做一个这个演讲。厉建安院士是美国国家医学院院士，是中国老年医学会的副会长，也是中国非公立医疗协会康复专委的主委。谢谢，请厉院士开始。
Good day, everyone. It's my great pleasure to join this session. I'm Dr. Li from Nanjing Medical University, and I've been involved in the COVID-19 rehab for since China is in this pandemic situation. I would like to share my little slides with you. Just a moment. We have to go onto the top. So everyone know from the name of this disease is COVID-19 is named by World Health Organization. That means this is a disease not only involved in our lungs, but also involving the whole body. But still in China, we call it coronary virus pneumonia yet, but actually this is not only respiratory infectious disease, but the infectious disease for the whole body. We have to realize a very important concept, that's clinical outcome measures. From the WHO, previously we said that the key clinical outcome are mortality and morbidity, but in year 2016, WHO say we should have the third clinical outcome measure, which is functioning. Functioning means a dynamic function. This is going to be a key index for efficacy of clinical management in chronic disease and conditions. So this is very critical, and we all know COVID-19 is the disease affecting not only lungs but our whole body, with dysfunctions with all organs, including exercise capacity, pulmonary function, cardiac function, liver function, kidney function, immuno function, and also psychological functions. And even though in China, the COVID-19 is getting over, in the majority part of China, there's no new cases. In our province, we haven't got new cases for 70 days. So it's a long time. But we still find out a lot of people after discharge from the hospital, they still have dysfunctions, including there's currently we have investigation in the major hospital of Hubei province, and the patients with the sleep dysfunction is 63.6. Poor exercise endurance is more than 60, and also mild dyspnea, anxiety, fear, and poor motivation. They all have a high incidence of those dysfunctions. That means after the acute stage of COVID-19, majority of our patients has got a certain need for further rehabilitation. Not only the pulmonary function, but also exercise guidance. The diet guidance is in very strong demand, and physical therapy, ADL guidance, and also appropriate Chinese medicine techniques. So we have to consider this post-acute phase rehabilitation. So I'm so happy this symposium is looking to this aspect. In China, because of this is a new disease, because it's unexpected pandemic situation. So the research is very weak in China yet, but still we have some research in rehabilitation ongoing, including I'm currently conducting 2 studies in COVID-19. One is telemedicine for home-based rehabilitation for COVID-19. This is a multi-center randomized study. It's going to be finished in about a few weeks. And also we are doing a study looking to ICF, which means International Classification of Functioning Disability and Health, which is also the second dictionary from WHO. We're looking to a new set for COVID-19. This study is done, it's under submission at this time. We of course are doing some research in traditional Chinese medicine rehabilitation, approach for COVID-19. Even though we haven't done a great study because we haven't done double-blind randomized study yet, but we're trying to do something. Finally, I would like to emphasize the Chinese government strategy for rehab in recovery stage. Our government announced several documents, national documents or provincial documents, to set up specialized rehabilitation hospitals in a majority part of China, and to encourage community-based or home-based rehabilitation, and to promote research and manufacturing for the smart devices for remote medicine in rehab, and also to facilitate physical fitness training to strengthen health conditions for whole country. Finally, it is really emphasized to promote the traditional Chinese medicine, to trying to confirm the role of TCM in prevention, treatment, and the rehab. So this is several points I would like to tell you, and I'm happy to chair the session with Adelina together tonight. Thank you very much.
好的，谢谢厉院士。那厉院士的这个厉院士的演讲非常的精彩。那下面呢，我们将进入我们的这个第一个环节。那第一个环节呢，其实是由我们3位的中国专家，他们分别是来自华中科技大学同济医学院附属协和医院的感染科教授赵磊主任，还有就是华中科技大学同济医学院医药卫生管理学院院长冯占春博士，还有就是武汉大学董夫人发展研究院的这个教授王健教授。3位教授将为我们带来这个中国的新冠的这个整个知识。谢谢，请这个赵磊教授先开始。
distinguished academician Li, distinguished guests, good evening, good night. It is really an honor to be here to share with all of you our experience and communicate with you our problems in the COVID-19. I am actually an infectious disease doctor from the Civil Hospital in Wuhan. We were the hardest hit hospital in Wuhan, the epicenter of COVID-19. We are just several different miles from the seafood market where the COVID-19 outbreak was ignited. So here we were fighting at the front line of COVID-19, providing prevention, control, and clinical treatment to the COVID-19 patients. Currently, we are also working on the research and development, screening, and follow-up study in Wuhan during the COVID-19 outbreak. In the medical side, we have experienced the whole picture of COVID-19 outbreak. Today, I'm really honored to share with you the experiences that we have accumulated in our prevention control and also the post-acute recovery stage. So I'd like to give you a brief picture about the prevention and control mechanisms of China during the COVID-19 outbreak. By the end of the 31st May, across the whole country, the cumulated reported case of COVID-19 is 83,000, with 78,000 people discharged from the hospital. The total mobility ratio is around 89%. The ratio of severe and critical cases is around 16% and 5.7%. This is the Chinese data. So here I'd like to share with all the colleagues from across the world and from the progress. In the year 1990, in 2019, we have reported the first case of COVID-19. By January the 7th, we have successfully separated the subtype of COVID-19 virus. And at the January the 15th, 2020, the National Health Committee has published the first guideline to treat the COVID-19. And at the 20th, we have seen the first case of the COVID-19 occurred in China.
In January 23rd, Wuhan closed all the transportation sites to other cities in the country. More than 360 workforce has been dispatched to Wuhan to support the treatment of COVID-19, including contact tracing and diagnosis. Since we started this effort, we see much improvement of the pandemic. We saw a decline in the diagnosed cases. After all these efforts, we saw the first time the patients discharged, the number of patients discharged more than the number being admitted to hospital. In March 6th, the number of newly diagnosed decreased further. In March 18th, China reported 0 case of newly diagnosed cases, and Wuhan reopened its transportation sites to other cities. And finally, we brought the number of diagnosed cases to 0. in terms of rehabilitation, I would like to share with you the 7th edition of the guideline about the guidelines for discharge patients. Number 1, the standard is temperature back to normal, and also improvement in several key symptoms, and also negative results for swab tests in 2 times in a row. So the first criteria, normal body temperature for more than 3 days, and also other criteria, including imaging improvement, as well as the swab test improvement. Of course, depends on the doctor's own judgment, which means we still need close follow-up of those discharged patients. And 2 negative results for nucleic acid tests also have some limitations, which means we might have false negative results. So this all means that we need close monitoring of discharged patients. And we saw recurrence in some discharged patients. So the criteria for discharging patients doesn't mean the patient's really cured or recovered. We still need close monitoring. For inpatient post-acute care, it involves how to care for mild and moderate patients, and the other is for severe patients. For mild or moderate patients, they basically have their functions recovered, such as their physical strength, their performance, but also mental health. For some patients, they need aerobic exercise to recover, including recovering their social activities. And also, the pandemic have some negative impact on their mental health. For severe patients, the post-acute care is even more important, because for severe patients, some of them experienced respiratory failure, such as respiratory distress. So most of them experienced pulmonary function failure. And also there are some patients who are severe because of comorbidities, and respiratory distress is only part of the symptom. They may have hypertension, diabetes, or even malignancies. Because when they recovered pulmonary function, the comorbidities still even need more care after they in the post-acute period. So for those patients, they need not only respiratory care, but also a comprehensive care and rehabilitation. And also post-traumatic stress syndrome is also very severe in those patients. When those patients are discharged from hospitals, they may have some sequelae, including respiratory disorder, cardiac disorder, and mental disorder. For respiratory disorder, mainly manifested as shortness of breath, And also cardiac disorder. Which all key factors involved in their daily activities. These are all maybe direct cardiac injury caused by the virus, or maybe because they rest in bed for a long time, and so they lose some pulmonary cardiac functions, and also maybe result from comorbidities like diabetes, and also they may have symptoms like fatigue and a loss of muscle strength. This is probably because of the fact that they rest in bed for too long, and also maybe some neuropathy caused by the disease. And another very common symptom like anxiety or depression, feeling helpless or angry, and also cognitive failure. For example, some patients find it difficult to focus their attention, and some of them may have lost their sleep function, and they may want to have an intention of suicide. Some may experience headache or a loss of appetite. Basically, many discharged patients may come back to the hospitals due to the above reasons. So in the patients revisited hospitals, we saw quite a lot of the above symptoms. And for patients, recovering patients, part of the reason is the way we collect samples, because we collect a lower respiratory tract. But ordinary tests only involve swab tests, which may give us false negative results. But we cannot make sure every patient can have a test of the deep throat or lower respiratory tract. And on the other hand, because of comorbidities like diabetes or hypertension, which lead to further loss of their body functions. So they may experience recurrence of the disease, or because the use of corticosteroid, they may relapse. And some patients may have fibrosis in their lung. For these patients, they may also test positive again. Generally speaking, the recurrence of COVID-19 in some patients need case-by-case analysis, but most relapsed patients have mild symptoms. After quarantine, they may fully recover. But generally speaking, and this group of patients need our attention in this post-acute care effort. according to the 7th edition of guideline, we still need to share with them the most updated information, and they need to quarantine for 14 days when they are discharged to the community, and then they should stay at home in quarantine for another 14 days, so 28 days in total. And we need to do follow-up visits to those patients. And their respiratory, cardiac, and physical functions, as well as mental functions, still have some problems. So during the 28 days after they leave the hospital, it's an important period for us to monitor. I'm sorry, Dr. Zhao. You can keep going, but today we have lots of guest speakers. You may save some time for them. I'm sorry. I will save time for our guest speakers. And some other things I would like to share is the clinical demands. For respiratory function, we need to give them some trainings, including aerobic exercise, and also for daily exercise, we need to give them some guidance, as well as give them guidance on pulmonary functions and cardiac functions.
So we need more exercise on the interventions in the psychological performance. So I think from that point, the Chinese experience, especially the Wuhan experience, just as Academician Li has shown us the data, it is also the data from Hubei and province and also Wuhan. A lot of patients need rehabilitations. As a clinician, we are in an urgent demand to talk with experts who have experience of the post-acute recovery. Thank you. That is my speech. Thank you very much, Professor Zhao. Right now, we'd like to give the floor to Professor Kong. Please share with us the recovery policies for the people infected with COVID-19. Distinguished professors, dear colleagues, it is really good day. So I think according to the requirement, I'd like to share with you the recovery policies for the COVID-19 patient. I am from the Huazhong University of Science and Technology. I'm actually working on the public health and the public health management. I'd like to share with you my slides in 3 different parts. The first part is about the policy background. Second, key policies that we have published so far around the rehabilitations and recoveries of the COVID-19 patient. For the third part, I'd like to give you an introduction of the local practice in Hubei. For the policy background, we all know that including Academician Li and also Professor Zhao has mentioned that for the COVID-19, it is a newly outbreak disease, and it is a plague affecting not only the psychology of the patient, it is also affecting the patient's mental activities and also their social life. So COVID-19 is not a common disease. It affects the patients in multiple fronts. Under this backdrop, when China is forming these recovery policies, it is actually following up the standards as put forward by General Secretary Xi Jinping, which is people-centered and life-centered. So no matter our early stage prevention, control, and treatment, and late stage rehabilitation and recovery, the very initial idea behind that is that we should be people-centered. The rehabilitations of the COVID-19 patient is not only about the self-recovery of the patient, it is also about the consolidations for what we have achieved in the battle against COVID-19. Under that backdrop, China, Hubei province, and even the city of Wuhan really cares about the recoveries of the COVID-19 patient. I'd like to share with you the policies from the two different levels, from the national government's levels and also from the local government's level. COVID-19, after its outbreak, because it's a newly acute disease, the diagnosis and the treatment is deepening, and across the whole country, we have came up several different editions of the prevention and control guideline. And when the COVID-19 is under fully control, we have already published the 7th edition of COVID-19 guideline. And at that time, that was a turning point for the COVID-19 outbreak in China. And in the 7th edition, we actually mentioned how the criteria for discharging patients with COVID-19 and also the post-discharge cares. In the 7th editions of diagnosis and treatment protocols of COVID-19, we actually noted that the designated hospital should actively share and send information to the community hospitals and community government about the patient's information, including the patient's medical record. That is how they are going to give the guidance to the community hospital to do a better job in the rehabilitations for the patients. Second, after the patient is discharged from hospital, the patient should undergo 40 days quarantine management under close medical monitoring. Then the patient can be back and discharged back into their community. After the patient recovered, we also put forward a very clear standard that the 2nd week and the 4th week after the patient is discharged from the hospital, they should come back to the hospital to do a retesting for their PCRs. The second part I want to talk about is that in the national level, the State Council actually published a general guideline for the working plans on the visiting and re-examinations of discharged COVID-19 patients. It noted several different parts, including the quarantine management. After the patient is discharged from hospital, they should be under medical observation for 40 days in a row. And for the community hospital, they should do a good job in the quarantines and also the health monitorings. The second part is about the review and the revisit of the patient. It is also quite clear that for each one of the designated hospitals, they should form up a very detailed plan for the review and re-exam of the patient. It includes the blood regulars, the pathological oxygen saturations, and also the epidemiological research, and they also included the respiratory functions and CT testings for the severe and critical patients, for the elderly patient and patient with comorbidities. It emphasizes about the health monitoring, and for the patient, especially for their inflammatory absorptions in their lung parts and also the fibrosis in the lung part, they should come up with a tailor-made interventions and intervention trainings and also psychological interventions. Then the third part I want to talk about is that there are a few patients who were tested positive, or we call it relapse into positivity. I think that we should enroll the patient into the hospital once again. And for this patient, even if they are testing if they have a PCR positive testing result with no clinical demonstrations, we should put them under quarantine. And thirdly, we should give more publicity to the general public and creating a very active environment across the society. The third document published at the national level is the National Health Committee's recovery plan on the discharged COVID-19 patient. And it actually came up several different targets for the recoveries of the COVID-19 patient, major targets and major activities. For example, for the major activities, it includes the evaluations, assessment of the recoveries and interventions for the rehabilitations, including the trainings for the respiratory functions, trainings for the body functions, and training for their psychological recoveries. I have introduced you the 3 documents which were published by the national governments. At the local level, take Hubei as an example, they also came up several different plans. In Wuhan, as the capital of Hubei province, in their recoveries, they have also came up with several different plans. For example, all the fees which were all the cost for the recovery is going to be covered by the governments. Secondly, for after the patient back to their own homes, we actually put forward the idea of the conducting health management, incorporate the health management with the essential public service, public health service. That was Hubei's idea about the COVID-19 recovery. It is going to be a part of the public health welfare, and it is also going to be provided by the basic level grassroots healthcare institutions, and all the costs is going to be shouldered and covered by the local government. The third idea I also want to talk about is that for the province of Hubei, they actually came up with a rehabilitation system to provide level-based rehabilitation systems. I have given you the ideas on the 3 different fronts across the whole province. They have 146 designated recovery institutions, and they should be giving the patient in-time guidance in their rehabilitation and recovery. Second, across the Hubei province, they have over 20,000 different grassroots level medical institutions. They should be responsible for the quarantines and also stay at home quarantine. And they should also provide the BPs, family doctors, for the discharged patients. So that is to say, every single COVID-19 patient after they discharged from the designated hospital, they should under a whole process management. Thirdly, we want to fully play the role of the traditional Chinese medicine. We have formed the outpatient department of the TCM for COVID-19. Fourthly, we have also emphasized once again about the internet price. The support should be provided through the telegraphic hospitals and family doctors, and all of the costs for this part should be a part of the public insurance and also the public welfare system. Let me give you a very detailed introduction. For example, the rehabilitations done by the traditional Chinese medicine in the Hubei province, they actually came up with local standards for the practitioners of the TCMs. They actually put forward the idea that for the outpatient department, the traditional Chinese medicines, they should have separated areas for the testings, waiting areas, CT scanning rooms, and also the health management department. And in that one patient department, they have the assessment centers for the respiratory functions, body functions, and psychological functions. And they also set up the evaluation areas, assessment rooms for the lungs functions. And they provided professional TCM experts to treat the patient, and it emphasizes our cross-discipline cooperation. They actually emphasizes that the diagnosis and the treatment should be combined with experts from the respiratory department and infectious department. And Hubei province also came up with the idea that there should be a coordinated effort between the hospital and community providing service for COVID-19 patients. And after the patient was discharged from the quarantine, at the second week, the family doctor team is going to appoint them and provided the rehabilitation service, among other different CT check-ins. And in the Hubei province, it's also quite clear that the community and grassroots level hospitals is going to do a follow-up testing for the patient 2 weeks after the patient discharged from the quarantine centers, and in the follow-up 4 weeks, they should monitor the patient health status day by day, and after 6 months, they should do a follow-up effort for every single month. Meanwhile, they should treat the comorbidities and underlying disease for the patient. For the patient who have some of the dysfunctions in their psychologies, we provided the volunteers and also the psychiatrist to service the patient. Apart from that, the city of Wuhan has also came up with the idea that for the patient who are in charge in the quarantine area in the Wuhan, all of the medical expenditures is going to be shouldered and covered by the government. That is the practice at the local government. Thank you very much for your attention. This is a short intro of what China has done at the national level and local government level. Thank you. Thank you very much, Professor Feng. Right now, I would like to give the floor to Professor Wang Jian to sum up the effort that we have done so far. Professor Wang, please.
Hi, good day. Respect to Professor Li and respect college. I'm Jian Wang from Dongfuren Institute of Economics and Social Development. So I'm going to share China's challenge and lesson learned from COVID-19. So I'd like to share 4 topics. The first is what health system issues are exposed by COVID-19 pandemic. After the pandemic, now can we improve the health system better rehabilitation service? The third topic is about how to deal with the 2-track, the instance of COVID-19 patient and other patient in the short term. Finally, I'd like to talking about something about strengths in telemedicine and the whole system in the long run for the rehabilitation. So the first is what health system issues are exposed by the pandemic. So as Professor said previously, it's not only public events, it's also a psychological crisis events. So let's look at the 3 aspects. For the patient, the psychological crisis intervention for COVID-19 patient is relatively lag behind in time and cannot effectively prevent post-traumatic stress disorder. So the worst psychological reactions such as fear spread in the groups of the patient, which has a negative effects on the treatment of the disease. And look at the frontline medical staff. And at the initial stage, lack of professional pre-job stress management training and routine psychological guidelines make some medical staff does anxiety and other psychological problems in the early stage. And the stress management training is carried out for medical staff to guide them to adjust their mood in the face of emergency and reduce their emergency sensitivity. And thirdly, provide effective social support system for medical staff. And for the public, the government need to estimate the public's condition and take effectively propaganda work, provide a method to relieve anxiety through the various media, ensure the accuracy and accuracy of official information, maintain the government credibility, and put an end to negative behavior such like cancellation information related to epidemic situation, and disclosing the patient's privacy. Correctly guide the public opinions and give affirmation and encouragement to the community, actively responds to the academic situation. And finally, for the public, also plans for the follow-up, long-term psychological assistance and service are needed. And my second topic is about experience of rehabilitation treatment for COVID-19. Previously, Professor said a lot, so let me make a kind of summary. The first is at the national level, establish rehabilitation evaluation standards, quantified the standard of patients' rehabilitation effects, and formulate targeted programs. And the function assessment include respiratory function assessment, physical function assessment, psychological function assessment, evaluation of daily life activity, and 6 minutes walking test. And second is about standardized rehabilitation training method and comprehensive rehabilitation program. So promote comprehensive rehabilitation, including social functions recovery for COVID-19 patients for their work provide rehabilitation treatment according to patients' condition. Third is establish a plan, a national plan. Establish rehabilitation, a national plan. It's consistent health management for patients after discharge. So COVID-19 patient discharge health management plan classified responsibility of health and the Ministry of Department at the different levels and medical institutions. Propose related health management work requirement before discharge. So discharge handover, discharge from hospital, taking the time period of discharge, and the vertical axis. The management requires the hospital, isolation place, and primary medical institutions to be prepared for continuous health care for patients, including discharge, handover, isolation management, post-discharge follow-up consultation, health monitoring, rehabilitation management, etc. So to guide a better follow-up health management provide for discharge patient in different provinces. So third, establish a national COVID-19 rehabilitation collaboration network in Hubei province. So the collaboration network has received positive response from dozens of medical institutions across the country to date. So including grassroots hospitals at the community level, and in the rehabilitation clinics, there may be experts involved in lung function, psychological, diet guidance, physical therapy, etc. So which forms a full process, multiple level, multiple method, and a wider range network system. So in the future, the medical institution in the collaboration network will provide rehabilitation patients with planned service, as well as doctors training according to research goals and develop rehabilitation medical team. And also traditional Chinese medicine has a remarkable effects in the rehabilitation of COVID-19 patients, and will participate in the establishment of a rehabilitation method. So there are a lot of reports found that there is some effects. For using traditional Chinese medicine in fighting about COVID-19 and also in rehabilitation. And the challenge, actually, I'd like to more focus on the financial system. As Professor Feng said, a lot of government funding involved in this area, and actually, China still need to explore the combination of the so-called basic medical insurance plus about commercial medical insurance to compensate for cost and expenditure that was not covered by the basic medical insurance. So the main problem actually is still existing is that the health system need to analyze the method of financial payment method and standard of rehabilitation medicine. The second challenge is about the position of rehabilitation medicine under the public health emergency. Because since 2008, in all major natural disasters like the earthquake, China's medical rescue team has contained rehabilitation medical experts. But this time, in fighting COVID-19, few rehabilitation medical experts were sent to Wuhan. In fact, rehabilitation medical personnel have generally entered the early rehabilitation work of the ICU and various clinical disciplines. So it plays an important role in shortening hospital stays, preventing and managing complications, preventing dysfunctions, and improve patients' physical functions, and improving clinical efficiency. So it's still a challenge to integrate rehabilitation medicine into the national emergency medical system or the host health system during the public health emergency. The third challenge about human resource management. Rehabilitation is extremely professional and comprehensive far beyond the scope of treatment medicine. So in other words, its extension broadly involves the independent integration of preventive medicine, public health, management, psychology, sociology, and the law. So its openness and evaluation are destined to form interdisciplinary research in social science, medicine, and engineering, actually. So the goal is to combine and to recruit the talent from the perspective of the health. So the fourth challenge is about application of information technology platform constructions. So to achieve a seamless connection between clinical diagnosis, treatment, and health management of COVID-19 patients, the challenge is to promote primary healthcare personnel in charge to improve the ability and the level of information technology and platform application learning, and make full use of online forms such as family doctors, GP, APP, cable TV network, and other means provide rehabilitation and management service for discharged patients. And fifth, improve the role of traditional Chinese medicine in rehabilitation of patients with COVID-19. And the traditional Chinese, some like the massage and acupuncture is really effective to reduce the pain. So
王教授，
that's
那
about
个
the challenge. And then the third is how to deal with the coincidence of COVID-19 patients and other patients. So let me have 6 points. The first is about the urgency of establish normalized, standardized, and precise prevention and control mechanisms to reduce the so-called spillover effects, and to make the two-track COVID-19 patient and non-COVID-19 patient to access effectively and accurately to the health and health care. Secondly, increase funding for prevention and control of hospital infections. Third, carry out the pre-post infection prevention and control training tests and the regular due for all staff, and do not take the post without training. So routine health monitoring and infection report on medical staff. Fourth, strengthen the pre-examination and change of the outpatient and emergency department. The fifth, take the advantage of online medical service, improve the method of appointment outpatient service, health code management, time-based outpatient service, online consultation and case discussion, online class, and online health education. Finally, improve the system of tiered medical service so that patients with common and frequently occurring disease can see doctors nearby and reduce trans-regional flow of patients. So finally, I'd like to address 2 points. The first is how to apply and strengthen telemedicine technology. So online consultation, online medical supervision, application of remote rehabilitation medicine, rehabilitation medical video, mobile app software vertical stance, logistic robot delivery, telemedicine, wearable equipment, etc., and various robots. So this is widely used in this time in fighting the COVID-19. So finally, how to promote the long-term of the healthcare system. Actually, we have internal call and external call. Internal call is about, we're talking about health service, system output, health outcome in the health system. But for the external call, actually we are more look at policy, culture, economic, resource, government, organization, and as well as behavior, environment, biology. So internal and external calls, they communicate and coordinate each other's. For instance, for the culture, it enhances the credibility of medical service and improve the relationship between doctors and patients. And for the organizations, strengthen the service capacity of medical institutions and implement their public health responsibility. And government for resource financing, collect the money and reimburse and pay the service equitable and efficientable. Thank you very much.
好，谢谢王教授。那也非常感谢我们中国的这个部分的来自武汉一线的3位教授的这个分享。那我得到的一个信息就是说，目前我们在这个至少在亚伯力的这个流量上已经有18万人来观看了，那是非常非常多的一个人数。下面呢，我们将把我们的这个话筒交给我们3位美国教授，把我们的目光投向大洋彼岸。这3位美国教授是 Dr. Ouslander 来自佛罗里达大西洋大学，还有就是 Dr. Grabowski， 他是来自哈佛大学的教授，还有 Dr. Mor from 这个来自布朗大学的教授。三位教授都是美国的老年病学和康复医学的权威，所以我们先把这个请Ouslander 教授第一个开始。Please, Professor Ouslander, thank you.
Good morning, everyone. I'd like to thank everyone for inviting me to speak, and congratulations to all the speakers. It's really an honor to be speaking with you. I want to say that one of my roles is I serve as executive editor of the Journal of the American Geriatric Society, and I would strongly encourage people who are presenting and others to submit their best work to the journal. And I apologize if I've rejected anything you've submitted or reject something you submit in the future, but don't take it personally. We have a special section in the journal now on COVID-19, and we welcome submissions. The first thing I want to do is to thank everyone across the world who provides post-acute care to a very vulnerable population. In the United States, these health care professionals are risking their health as well as the health of their families every day under very difficult and in the United States, often very under-resourced conditions. I've created a set of slides. They have some detail. I'm sure they'll be available to you. I've also provided references, and I'm going to try to provide context for our other American speakers, Drs. Grabowski and Mor, about post-acute care in the United States and some of the key insights that I've thought about. So I'm going to try and make 4 key points. I'm going to talk a little bit about the setting and the population of post-acute care in the United States, which will provide context for the other speakers' remarks. Talk a bit about managing transitions from the hospital, which our colleagues from China have already mentioned. Talk about other approaches to preventing further devastating clusters of COVID-19 in nursing homes. There have been many, many tragedies across the United States. And then finally, to talk about some opportunities that the pandemic provides to improve care in the post-acute care setting. So first, the setting and the population. In the United States, post-acute and rehabilitative care is provided in a wide range of settings that vary from acute rehabilitation and long-term acute hospitals to skilled nursing facilities, which are also known as SNFs, SNFs, and nursing home. And is also provided in the home with or without skilled nursing or rehabilitation therapy. And the choice, as illustrated in this figure, of which post-acute care setting an individual person goes to is a very person-centered decision that involves, a lot of it involves location, so they can be close to family, their previous experience, the availability, the cost, the quality, as well as hospitals now have post-acute care networks, so they preferentially refer patients to those networks. I'm going to focus my remarks on the skilled nursing facility or nursing home setting, and I think the other speakers will as well. There are somewhere around 15,000 nursing homes in the United States, and at any one particular time, they're caring for 1.5 million people. The median size is about 100 beds, and the average census has now gone down to about 83%. Between 1 in 3 and 1 in 4 hospitalized older patients are discharged to a nursing home after their hospital stay is over. And people who are cared for in SNFs are there for very different reasons clinically, as shown on this diagram. There are patients, what I refer to as patients. They are short stay patients. They're there for post-acute care, rehabilitation, functional improvement, or they're because they're medically unstable and require ongoing medical and nursing management, or they're terminally ill. And then there are residents who who live in the facility, and they live there because they don't have the social support or the economic means to live at home. And they have generally have a mixture of cognitive and physical impairment. So in these average 100-bed facilities, there's a mixture of these short stay patients and long stay patients. I've called, and others have called, the skilled nursing facility setting or the nursing home setting in the United States a perfect storm for the transmission of this virus. The patients and residents are at high risk for complications and mortality due to multiple chronic conditions, advanced age, and altered immune function. They live in a congregate setting, and in most United States nursing homes, they are mostly double occupied rooms. There are some facilities that have single occupied rooms, but most have double. The staff and clinicians who come in and out of the facility often work in multiple healthcare facilities and come in and out frequently and can be asymptomatic or pre-symptomatic and shedding virus without knowing it. We know that there's a non-specific and atypical presentation of COVID-19 in this population. And as I mentioned, there has been a severe lack of resources in many nursing homes in the United States for viral testing and personal protective equipment. So all of these factors have created this perfect storm that has created dozens and dozens of tragic situations where in nursing homes, a large proportion of the patients have acquired COVID-19 and many have died. So one of the ways that we, one of the key ways that we are trying to control the spread of the virus in the nursing home setting is that most people who are initially admitted to a nursing home are admitted from a hospital. And optimally, we require 2 negative viral tests at least 24 hours apart, optimally no longer than 72 hours from hospital discharge, and resolution of symptoms and no fever without acetaminophen for at least 3 days. I think that's pretty much a standard in the United States and should be. The other thing that's a standard and makes it somewhat challenging is that regardless of testing status, all new admissions from the hospital should be isolated for 10 to 14 days, which is following our Centers for Disease Control and Prevention recommendations, with only rare exceptions, because the virus can be acquired between the time of testing and hospital discharge, and the test can be falsely negative. And so that requires anyone who's newly admitted to a nursing home to be isolated, assuming they have the virus until they're proven not to. And many skilled nursing facilities have been able to develop dedicated COVID-19 areas. It's difficult in many facilities with separate staff where viral positive patients and persons under investigation are isolated. And I think David Grabowski is going to address more about that issue. So other approaches to further preventing devastating clusters of COVID-19 in United States nursing homes. We have to continue to be vigilant as our society opens up. I don't know if those of you from other countries understand what's going on in the United States. Our leadership, our current administration really has, in some senses, washed their hands and is now making the situation seem like it doesn't exist. Many states are opening their societies up and people are not cooperating with public health measures, including the state that I live in, and there have been dramatic increases in the number of cases being identified in almost half the states in the United States. And despite that, they continue to open up society. It's really a volatile situation right now. Part of that is because of increased testing, but part of it is because of a failure to public health prevention measures. And skilled nursing home settings are like a tinderbox waiting for a fire. And I'm very concerned about this because one individual person, whether it's a staff member, a doctor, anyone coming into the facility, one person could light the fire. And so we have to continue to be vigilant. And the best way that we have is intensive infection prevention and control education and policies. And our federal government is now focusing the regulatory and survey process solely on infection prevention and control. This includes screening all staff, clinicians, and contractors and vendors who come into the facility with questionnaires and temperature, to limit visitors except in areas with low prevalence of the virus, and use outdoor visits and social distancing. And that's just starting now. Everyone in the nursing facility should use masks at all times. And when interacting with patients, they should optimally use a mask, eye shield, and gloves. Proper use of protective equipment when caring for COVID positive patients and persons under investigation. And the other thing I want to emphasize is because the presentation of COVID is so nonspecific in this patient population, you have to have a very high index of suspicion and a low threshold for isolation with any acute change in condition. So we now recommend that in many nursing homes for long stay residents at least, vital signs are taken once a week or once a month, but we're recommending that they be taken at least every 8 hours, and the trends followed very closely. And any change in condition, there should be just again a very low threshold for isolating that person until they're proven not to have the virus. So other approaches, making the availability of rapid, accurate viral testing. This is still a major problem in nursing homes in this country. Staff and clinicians not known to have been previously viral positive, assuming that we can get accurate viral tests, I believe they should be tested at least weekly, and if possible twice per week, given the rapid shedding of virus after it's acquired. And this is especially important in the states that are opening up, businesses, schools, etc., which will potentially expose more nursing home staff more frequently to the virus. Staff who work in multiple healthcare facilities, doctors, and other staff that go in and out of multiple cities should be a high priority for repeated testing. And many staff will be found viral positive without knowing it, and that requires facilities to have backup staffing plans. And this is very, very difficult and expensive in the United States. The other thing I'll just address is some thoughts about serologic testing. I'm not an expert in this, but, and this is very controversial. Those of you may have seen a kind of article that was written about this in the New England Journal of Medicine last week. So I think that this can be helpful for serologic testing can be helpful with caveats. That is, the level of antibodies that are protective against COVID-19 are not known. The duration of immunity from the antibodies presumed to be protective is not known. And the antibodies don't start developing for 6 or 7 days after infection, and the timing of the test is therefore important. But with those caveats, I think that it's reasonable to assume that staff that are tested positive who have antibodies might preferentially be used to staff the units that have COVID-19 and patients and persons under investigation. And I wonder if other countries are doing that, are planning to do that same thing. So finally, I just want to talk about some opportunities this pandemic has presented to improve care. The first is that this pandemic has highlighted the need to further efforts that have already been underway in the United States to reduce unnecessary emergency department visits and hospitalizations of nursing home residents and patients. Clinicians should balance virtual and in-person visits based on the clinical situation. I don't know about the availability of telemedicine in other countries. True telemedicine, where you examine patients in the United States, is not widespread, but a lot of visits are being done by telephone. And our federal government has changed the payment rules and requirements for in-person visits and telemedicine to enable that. There are a variety of tools available to clinicians to try and help evaluate and manage patients in the nursing home without transferring them to the hospital, including the American Medical Directors Association has clinical practice tools. The Interact program that I've been involved in developing has a whole set of free tools that are on the internet at the address listed on this slide. The second approach that many have taken is to improve medication management and deprescribing. A group of experts led by PharmD at University of Maryland developed a guidance for optimizing medication management during the COVID-19 pandemic. It's free, it's available at the website that's listed there. And the rationale for doing this, other than the fact that we know there's a lot of polypharmacy and unnecessary medications, is to reduce risk of viral transmission during medication passes, to decrease the staff burden and time of administering medication and monitoring things like blood sugar and blood pressure, to decrease the risk of adverse drug reactions, and to decrease the overall cost of care. So there are several strategies that can be used, but one of them that I've been advocating and had before the pandemic, right before the pandemic, had summarized some papers that we published in the Journal of the American Geriatric Society and elsewhere that show that people in nursing homes with life-limiting illness are frequently prescribed unnecessary medications. Just as an example, as you can see on this slide in the green bar, about 1/3 of people with life-limiting illness in nursing homes are prescribed a statin. There is absolutely no evidence that they're effective. There are about 30% of people who have severe cognitive impairment or are terminally ill are still prescribed cholinesterase inhibitors. Hypertension is overtreated. Diabetes is overtreated. And we need to improve this, and this pandemic has provided an opportunity and rationale to do that. And finally, there are opportunities to improve advanced care planning. The mortality rate from COVID-19 is high in the nursing home population, and clinical deterioration can occur very rapidly, so that we don't want to send people to the hospital and put them on respirators when they're at the end of life to begin with. So that we are really advocating advanced care planning by the multidisciplinary team that works in nursing homes, and also to engage local palliative care and hospice clinicians where they're available. And there are many tools for this. There are many tools available on the website. I've provided some web-based resources. But the main point is that this is not just a matter of writing an order that's common in nursing homes, like do not resuscitate. That's not helpful. We need to try to talk to people that this virus could cause respiratory distress very quickly, and that we don't want to send them to the hospital. We want to try to keep them comfortable in the facility. And that requires that the facility be prepared in their emergency stock, that they have medications that can provide comfort in the nursing home, such as liquid morphine and lorazepam and atropine for secretions.
Okay, thank you, Professor Ouslander. Thank you. By the way, we have like people online about like 500,000 at currently. So next we will move to speaker Professor Grabowski from Harvard University. Thank you.
Great, thank you everyone. It's a real honor to be here with everyone today, and what a great opportunity to have colleagues from China, the US and Europe all together spending some time and talking about rehabilitation across our different systems. So Dr. Ouslander provided a great overview, and I'm going to talk specifically about policy design and implementation of post-acute care, what we've done in the US well, what we haven't done well, and what we're still working on. So next slide, please. So I published a paper in the Journal of the American Medical Association, or JAMA, with my colleague Karen Joint Maddox back in March, right as the pandemic was starting here in the United States. And we outlined a series of principles that the post-acute care sector needed to think about in terms of getting ready for the surge. The US was very focused at that time on hospital resources and hospital capacity and capability. There was very little discussion of post-acute care capacity and post-acute care capability. And so we really wanted to kind of broaden our thinking here in the US to encompass post-acute care as well. We outlined a series of principles, and I'll just quickly outline those. First, we want to test everyone leaving the hospital. I know that seems very basic, but at the time, there was this real push to discharge as many patients as possible from the hospital to the different post-acute care settings that Dr. Ouslander spoke about, like nursing homes or home health agencies. And there wasn't, at the time, a lot of testing capacity. And so we were really encouraging that everyone needed to be tested regardless of whether they were COVID positive at the hospital. Next, we outlined a plan or an idea of having these specialized COVID-only settings. And what we meant by this is that there isn't a strong rationale or case, as Dr. Ouslander said, for most nursing homes or other facility-based settings to care for both COVID and non-COVID patients. They just can't do that safely. They don't have the staff or the resources. And so we really wanted to push the post-acute care sector, especially those facility-based providers, to really create COVID centers of excellence. And those could either be in existing facilities that become completely COVID only, or it could be a unit or a wing or a floor or a building as part of a broader campus in which this particular unit would be COVID specialized. Another idea was going out and finding facilities that had closed, either hospitals or nursing homes, and basically reopening them, retrofitting them to be COVID only facilities. And finally, there was this interest in using big spaces like convention centers and arenas as recovery units. We also noted that not everyone's going to be able to be cared for in a facility-based setting. And for some individuals, there may be home-based care models that are appropriate. We should invest in those and use them because there's a much lower likelihood of spread of the virus with a home-based discharge. And then also finally, and this point I'm gonna really stress, and Dr. Ouslander already teed this up, we really need to support our workforce. And that means getting them testing, personal protective equipment, hazard pay, paid sick leave, just being able, the workforce is fragile and they need our help. And so we really argued that if we're gonna get the post-acute care sector ready for the surge of patients, the workforce is the key kind of support for that. Next slide, please. So let's think a little bit about how the US has done. First, what have we done well, and at least well in some areas? I think some states have done a really nice job of creating these specialized settings, these centers of excellence. So I'm pointing towards Connecticut and here in Massachusetts where I live. We've seen a range of models from creating specialized centers in existing facilities, either a unit or completely creating a COVID facility. We've reopened facilities in Connecticut, for example. Here in Boston, we're using our convention center. They've named it Boston Hope, and there's 250 beds in the convention center that are dedicated to post-acute care. So that's been really encouraging, and we've seen these models in other states around the country. The other thing I think we've done well, and Vince Mor, who's going to speak next, and myself published a piece in the Journal of the American Medical Association, again, talking about hospitals really needing to get involved in post-acute care. And we've actually very much seen that to date here in the US. That facility I mentioned, Boston Hope, here in our convention center, a big hospital system is actually running that. And the hospitals have been more involved, I think, than they've ever been in post-acute COVID care. And so that's been a real positive. And so I think there are some bright spots in our response. Next slide, please. However, there's also been some real kind of negatives. And I mentioned the fragility of the workforce already, but I think they're fragile from a physical standpoint. A lot of them have gotten sick. They're fragile emotionally, some mental health issues. And then of course, you know, they're fragile financially. This has been really hard on them. And so we need to continue to support them. And I don't know that we've done a strong job of that thus far. I would also suggest that our lack of personal protective equipment has been a national disgrace. Many frontline direct caregivers in the US have not had personal protective equipment. They have been the sort of silent spreaders within these buildings, largely because they picked this up in the community and then brought it into the nursing home. And then I'd finally say that we've done a relatively poor job of testing in many states. Some states have stepped up, but many haven't. Dr. Ouslander already mentioned the sort of underinvestment by our federal government. They basically pushed this issue, all of these issues, out to the states, both the logistics of coordinating the response to COVID, but also the costs of COVID. Some states have done some good things, but many states haven't. And so I've really argued that we need a sort of a coordinated federal effort here in the US. And I'll just use an example of differing state responses with testing. You know, Ohio has used the National Guard, for example, to do testing. New Jersey has taken the onus from the federal government and then just pushed it down to the facilities and said, you know, we're going to require that nursing homes figure out the logistics and costs of this. And then finally, Alabama, for example, has just ignored the federal recommendations around testing altogether. We need the federal government to sort of own all of these issues around workforce, around personal protective equipment, and around testing. Next slide, please. So there's several parts of this that I think in the US we're still working on, and I would say our response is still incomplete. Medicare, which is our predominant payer here in the US for older adults, they've tried to encourage more home-based care, and they've relaxed some of the rules where we can allow models like hospital at home. So you're no longer paying just for hospital or post-acute care in a facility, but rather allowing the same set of resources to flow into somebody's home. It's really unclear to me whether we're there yet in terms of the infrastructure and the models around the country. And so I think it's encouraging that our government has allowed greater payment flexibility, but our entire kind of delivery system can't pivot so quickly to actually provide these services. Dr. Ouslander also mentioned home health care here in the US. That's been very therapy driven in the past. I think it can be a part of the recovery for COVID. It could be part of the model for recovering COVID patients, but I'm not 100% certain that home health care alone is enough for most of these patients. We've heard a lot from our colleagues in China already and Dr. Ouslander about just the needs of these recovering patients. They're going to need a lot of different services. And so it's not exactly clear to me that the US home health care model as currently structured can take on a lot of these patients. They can certainly play a role, and they are playing a role, but I think we just want to be careful about taking all those patients who previously would have gone to a nursing home, for example, and discharge them to home health care. Final slide, please. So I wanted to wrap up by saying we're far from out of the woods here in the US. COVID hospitalizations are increasing in many states. The data do not look promising. And so if hospitalizations are increasing, we're obviously going to need post-acute care for these patients. So many states that haven't yet thought about their post-acute care capacity are now going to have to face this issue. I hope they're planning ahead. I worry that they're not. I also think in some of the states that have already faced the huge initial surge, like here in New England and the Northeast, there's obviously a potential for a second surge later this year. And so I do think we have to remain vigilant on this issue. We still need to continue to invest in post-acute care capability and capacity around the country. And I think that the takeaway there is that this issue isn't going anywhere. We still have a lack of personal protective equipment. We have a lack of testing, and we're really not supporting those healthcare heroes, those direct caregivers, as much as we should. And finally, I would just say that the model I really have been advocating for since March here in the US is prioritizing facility-based settings that are specialized, that can really cohort those recovering COVID patients such that they're not infecting other patients, and then finding those strong home-based models that we know are quite good at isolating recovering COVID patients from other patients. So I'll stop there and say thank you. What a great opportunity to present this work today. Thanks.
Thank you, Professor Grabowski. And let's move to Professor Mor from Brown University. And Professor Mor, please give us a summary. Thank you.
So good morning, good afternoon, or evening, wherever you are. It's a pleasure to be here today to speak with you. I'm going to be speaking with you about some data that actually we're working on jointly. So I will not be focused on policy and as Joe and David did, but I will be talking about the issue of COVID in the US with current experience. I'd like to acknowledge a large number of people on my research team, as well as funding from the National Institute on Aging. So what first I'd like to do is describe a collaboration between our research group at Brown and clinical leadership of a large nursing home company to help understand the phenomenon of COVID in the nursing home, to then describe some of the predictors of the nursing home outbreak and spread, and then describe the predictors of symptomatic and asymptomatic positive nursing home cases, such as Joe talked about. And then finally, to describe predictors of mortality, and then talk about future sort of critical issues of importance and what the residual questions are. So Brown has been working with a company called Genesis Healthcare. They own and operate about 400 facilities in 26 states across the US. They've been collaborators with Brown Focus in past studies. And so in April, we agreed to have a crash cooperative agreement in order to examine in detail their data on a real-time basis in order to help them understand and address critical and operational questions. So the first set of questions were, what are the predictors? Who's getting it? Who's not getting it? And what influences the spread? So here we see that it's the total number of beds. So that in a large size of facilities, facilities that had at least one case versus facilities that had no case. It was also facilities that had a higher proportion of African American patients in it, and also facilities that were in areas which are much higher density population. And of course, the most important determinant of all is if a nursing home is in a county with high numbers of existing community cases, that has the highest influence on whether or not there's an outbreak. Not only is the issue of whether there's an outbreak, but also how many cases. So on the y-axis here, we have this, the skilled nursing facility cases per 100 beds. That is basically how many patients in the building have COVID. And on the x-axis, we have how many people in the community have the condition. And here we see it's a fairly strong relationship over time, over this period. It's about a correlation of about 0.62. And it's very strong understanding that the more cases, the more likely you are in an environment. So this is all about outbreaks are unrelated to facility quality, rather they're related to the transmission risk that it follows. This is a very important point because if you understand what is causing, then you'll understand what's the solutions. And if the solution is poor quality facility, then you worry about those bad actors. If the cause is community engagement, then you have to monitor the extent to which people from the outside come in. And right now, as David mentioned, as Joe mentioned, we're opening up nursing homes across the country. So that's going to be a major challenge to actually mitigate the risk of infection of the people entering nursing homes. Facility size is a really important factor, and it just reflects the amount of traffic, how many people come in. Because high prevalence, because staff tend to live in high prevalence areas. Most staff working in nursing homes are from poor communities. As we've seen in New York City, the highest rates of infection in the community are in the poorest communities in those areas. So as David suggested, we need regular staff testing. It would be wonderful if there were a less invasive test that we could do on a regular basis. So symptoms that are associated with COVID-19 testing. So we've looked at temperature monitoring, and it suggests the temperature at a lower threshold than what is currently suggested is better. Really low oxygen saturation also matters. And there may be some risk for identifying a clinical configuration of symptoms. So here we see that in the days preceding a COVID positive test, patients who are in the positive, who become positive as a result of that test, their temperatures go up. Now you look closely at the temperature. This is in Fahrenheit, not centigrade. But as you'll see that 98.2 is the average, which is significantly lower than 98.6. So this is the sort of the geriatric baseline. So when CDC says we have 100 degrees, 0.4 is the threshold where you should begin testing. For the geriatric patient, it's far lower. The oxygen saturation levels, also for the positive test, they begin to drop, but that precipitous drop is only a few days before. So that's something that you have to monitor also very carefully. The folks at Genesis have been monitoring this 3 times a day, exactly as Dr. Ouslander suggested, and these data are reflecting of that. So we've begun looking at, very preliminarily, certain configuration of symptoms. And so, for instance, if you're looking at nausea, vomiting, diarrhea, and a high temperature over 99.2, you have basically a positive predictive value of 0.62. But if you're looking at cough, high temperature, and declining oxygen saturation, that ends up with a positive predictive value of 0.88. And so you have to balance these off, deciding on which ones you want to test. We're going to be applying some artificial intelligence applications to these over a much larger number of cases in the near future. And hopefully we'll come up with something that, in the absence of daily or weekly universal testing, if you're monitoring patients, you can monitor this as well. So as I said, this could combine this with monitoring inclines in community virus spreading, particularly because not all areas of the United States have high virus in the community. When that begins to arise, then that's when you need to monitor even more carefully in the nursing home setting. So we've got some early results regarding predictors of mortality amongst COVID-19 positive patients in the nursing home setting. We define mortality as 30 days from the date of test and all-cause mortality, because we don't actually know all of the features about COVID mortality. It's 23% of symptom-identified positive cases died within 30 days, and that's only 14% of sweep-tested cases. That is, cases who are in facilities where everybody in the building was tested on a given day as a preventive or general epidemiological examination. What's interesting is that this mortality rate is highly differential as a function of the characteristics of the patients. So 30% of those 85 and over died within 30 days, 28% with a dementia diagnosis died, and 36% of patients with severe cognitive impairment died, giving you a real figure of the understanding of what are the determinants here. Multivariate analyses have revealed that age, particularly very high age, cognitive and ADL functioning impairments are the most important predictors, and they swamp the effect of any individual diagnosis. So functioning, cognitive, and physical are really important factors. So this could be, as Dr. Ouslander suggested, a way of targeting specific patients when they test positive for saying these people have a very low likelihood of making this or a very high likelihood of dying. And we may want to have a full court press to see about providing palliative care, comfort care, and advanced care planning discussions. So these outbreaks occur in nursing homes that are located in densely populated neighborhoods with prevalent virus. The spread in buildings happens in larger facilities because there's more traffic. The outbreaks seem to be completely unrelated to our current ways of defining quality. That might change over time as most facilities should have adopted and figured out how to manage this so that the next wave might be more related to a true ability to manage infection control, but this past wave has not. The Centers for Disease Control temperature threshold of 100.4 is probably too high. And then we could develop some form of symptom-based algorithm to identify testing that could be done earlier. And it might even be, because of the level of false positives for some of these tests, presumptive testing that, you know, if this person is that sick and that many symptoms, even though they're tested negative today, try to test them again tomorrow because they look like they have the virus. So that age and impairment are far more important than disease-specific risks. So the next steps are, you know, it's really critical for nursing homes operating now, accepting new patients from the post-acute care, accepting and admitting family members to come in to see their patients, and then grappling with more and more and different kinds of providers coming into their buildings. They're going to be opening up their buildings for more infection. So we need to understand and we need guidance on what's the most efficient testing protocol for patients and staff. What's the proper balance between PCR and serology? Both the PCR testing and the serology testing, those things are advancing very rapidly now. We need to have that because once, with the proper provisions, serology is better understood. You can begin to say, if this is a staff member who has positive antibodies, for some time, that person may be safe to work with all staff, with all patients. How much to deal with this issue of local disease prevalence? How do you properly model? How do you monitor that? And then how should the nursing home respond accordingly in preparing for what is likely to be an event that someone's going to bring in with them, some transmission? Because there's got to be the right combination of clinical monitoring testing. It's just not sensible to be testing every staff person and every patient in rural Montana where there is no virus in the community. The most important critical question now is, can frail nursing home residents be reinfected? How much is this disease going to look like flu, where every year we have to refigure a new vaccine, a new mechanism, and a revaccination? Consistent with a senescent immune system needing more boosters, is this going to be something that we're going to have to actually struggle with as part of our testing? This has massive implications for vaccine design and testing. And I would venture to say, as we move forward, I don't think we should actually be developing a vaccine just for the community, just for nursing home, for healthcare workers. We should actually be thinking about how this vaccine works in old, frail people, a lot of whom live in nursing homes. And this is something that we can actually do testing for. So thank you very much for that.
Thank you for your sharing, Dr. Mor. So 我们下一步就是结束了这个3个美国专家的分享。那下一步我们将会把我们的视线越过大西洋到了欧洲。那么欧洲我们也请了3位这个就是在老年病和康复医学领域的著名专家，他们是这个 Professor Achterberg from 从荷兰来，还有就是这个 Professor Bärnighausen 他是来自于德国的海德堡大学，还有就是 Professor Knapp from 他们是从伦敦的这个伦敦政治经济学院来，所以从英国、荷兰和德国。 下面我们把这个话筒交给 Professor Achterberg. Thank you, Professor Achterberg.
Hello, my name is Wilco Achterberg. I'm a professor in elderly care medicine, or one could also say nursing home medicine in Leiden, the Netherlands. The Netherlands is not only famous for their windmills and wooden shoe, but also known because they have a very strong long-term care system, especially educated nursing home physicians and strong multidisciplinary teams working in that. They are also educated in geriatric rehabilitation, and a part of the Dutch nursing homes have been transformed into skilled nursing facilities which perform geriatric rehabilitation. Netherlands have been hit by COVID-19 early March this year, and after several weeks of lockdown and high pressure on hospitals and intensive care units and high numbers of deaths, we are now in a much quieter phase, as you can see. As in other countries, older persons, male sex and more frail persons were hit the hardest. And 27% of the hospitalized patients were admitted to the ICU. Our number of cases per million is with 2,800, lower than in the UK with 4,200 cases per million, but higher than, for instance, Norway with 1,500 cases per million. As you can see also, the death rate is between Norway and the UK. Half of all the Dutch COVID mortality was in nursing homes. Interestingly, we have good data on the use of the intensive care unit and on mortality, but we have very poor data on the use of post-acute care in this situation. One might expect, as hypothesized by Grabowski, that between 30 and 50% of COVID-19 patients would require post-acute care. As we look at the clinical characteristics of COVID-19, the comorbidities that are so prevalent in them, that also have been mentioned by our Chinese colleagues, and the complications, it is easy to understand that we see multi-domain problems and a variety of functional impairment. These usually are characteristics that qualify for post-acute rehab. We see patients experiencing pulmonary problems combined with the cardiac complications and neurological damage and huge muscle loss combined with psychosocial stress. It is clear that we need a multidisciplinary and holistic approach for these patients. We see not only a variety in post-acute symptoms and impairments, but it's also interesting that we see a variety in severity. Some patients are admitted for geriatric rehabilitation that are only able to sit for an hour a day, have speech and swallowing problems. Others predominantly suffer from psychosocial stress, depression, or cognitive problems. For patients after hospital discharge, we have made 4 groups. The first group is a group of patients with mild symptoms. They can go back to their own home. They may receive home care and, if needed, therapy, of course, by physiotherapist, speech therapist, or dietitian. The second group have more problems, but are not so complicated that they need multidisciplinary rehabilitation. However, they are not able to go back to their own home. These patients receive low-grade care in a nursing home, often on a special post-corona cohort ward, or to specially made corona hotels. And I will get back to these hotels later. The third group is a group that has comorbidity and frailty and or impairments in several domains that require multidisciplinary rehabilitations. And these patients go to the geriatric rehabilitation ward of the skilled nursing facilities. The fourth group are often the little bit younger group with high premorbid functioning and high goals for reintegration, and also many impairments. Often they survive the intensive care units, have post-intensive care syndrome, and even post-traumatic stress. They are supposed to go to specialized rehab centers, including specialized lung rehab centers. Well, this is a hotel, Van der Valk Hotel in the south of the Netherlands, which was hit the hardest with COVID. So it was empty due to the lockdown, and it was transformed into a corona hotel. And as you can see, even the army soldiers assisted the staff that was recruited from local nursing homes. It was directed by nursing home organizations in the region. Our Minister of Health, Hugo de Jonge, can be seen in the right bottom picture, inspecting this, showing his famous shoes. This hotel had a capacity of 300, but at the peak it had only 30 patients. And since a few weeks ago, closed again because it was no longer necessary. As Europeans may know, the Eurovision Song Festival is a great thing. It was supposed to be held in May in Rotterdam, in the Ahoy Convention Center. The Song Festival, of course, was cancelled, and the convention center turned into a very large corona location. It was a great effort, but it did never see a patient. The skilled nursing facilities did receive patients for geriatric rehabilitation, but also here in many parts of the country, the capacity that was built was much overstated. Here you can see an impression of a geriatric rehab facility that is part of Topaz, the nursing home organization that I also work for. And it is next to the Leiden University Medical Hospital, where I also work. It was good to see that hospital specialists work together with elderly care physicians and rehabilitation physicians in multidisciplinary team meetings to discuss the best post-acute care setting. Next to patients being admitted to hospital, many patients stayed at home. Also, these patients have many long-term symptoms and impairments. We have tried to make a schedule, it's in Dutch, but in 4 rows in which we summarize all the patient pathways. First, we assess where the patient was during the infection, at home, in the hospital, or on the ICU. Then we assess the clinical profile, and we divide this in 3 things. Persons that are specific with deconditioning, with PICS, or with a pulmonary profile. The 3rd row in the schedule represents the available care settings, such as low care in a nursing home, geriatric rehab in a skilled nursing facility nursing home, ambulatory rehab or specialized lung rehabilitation center. And the 4th level represents the care after post-acute institutional care, which can be relatively simple or more comprehensive. The experience we have until now, and as I said earlier, we don't have good data yet, is that we see a very unpredictable course of post-acute functioning. Many patients admitted for post-acute care often can be discharged home after a few days. On the other hand, general practitioners tell us they see many patients with long-term complaints, severe fatigue, and emotional problems. Planning has been difficult. Large capacity for post-acute care has been developed, but not used. Geriatric rehabilitation has been underused, I think. Feedback from parts of the country was that sometimes hospitals were reluctant to discharge patients, although they were fit for rehab. Because other care activities were stopped, some suspected economic arguments. Empty beds is bad for business. However, because the geriatric rehabilitation is in nursing homes, the patients knew that if they went there, they had to face the no-visitor policy. After such a traumatic infection, family and loved one visits sometimes took over the priority over rehabilitation. Patients, hospitals, and nursing homes also struggle how to handle the potentially contagiousness of these post-acute COVID-19 patients. And sometimes that is led to no or late admission to post-acute care settings. What we see in the lack of data on post-acute care services reflects the attention Dutch policymakers had for the different care settings. Especially testing and personal protective measures have been very poorly available, just like in the USA, outside the hospital in the first 2 months of the crisis. And the focus was almost entirely on planning of ICU beds and facilitating hospitals in all kinds of ways. I think we are now better in balance, and both protocols and capacity are in order for post-acute care settings. Regarding the lack of data, we are in a few weeks starting a European cohort study on COVID-19 rehabilitation under the umbrella of the EU GMS. We hope to get more data. This is, as we all know, extremely necessary. So I would like to thank you very much. And of course, you may contact me if you have any further questions.
Thank you, Professor Achterberg. Next, let's move to Professor Bärnighausen. Theo?
Yeah, thank you. I'm sharing my screen. Can you see it? Can you see my slides?
Yes, yes.
Excellent. Yeah,
Okay.
thank you to
Excellent.
the previous speakers. Very inspiring, and I learned a lot already. And thank you in particular to the organizers. One of the many innovations and policy innovations that COVID-19 has given us is medical nationalism. And I'm grateful for a global conference across many continents in different time zones to fight national medicalism. We in science, I think, have responsibility to fight it, because we learn from each other, and we learn from each other for policy design and implementation. And that's the topic of my talk. I'm not a, I'm a family doctor by first training, and thus, of course, have a root in also treating patients in nursing homes and long-term care facilities, but I'm more a population health intervention and policy researcher. So my perspective will, I think, complement nicely those of the outstanding geriatrics and nursing home care experts that we've heard previously. One question to me as a population health researcher, which is very important for the long run, and I'm excited that we will gain the data to answer it, is, are there long-term care, post-acute care needs, gradients by age, and how do they manifest? And how do they manifest in populations that we do typically not see in the formal healthcare system, not in hospitals, maybe in primary care? Do they manifest themselves in similar needs to the well-known mortality gradients, or in different ways? And here's indirect evidence. You've probably seen similar studies. This is our version, a rigorous demographic study under re-review in a good journal, where we take out the mortality, the age difference in the mortality gradients of COVID-19 worldwide. And we see this is from all countries where at the time, this is many weeks ago, we had complete age distribution information on COVID-19 in all those countries. And we then take out, through age weighting and age standardization, two different ways, the mortality age gradient in case fatality ratio. And this shrinks the gradient from a factor 1 to 10 to a factor 1 to 3. So age does explain a lot of the cross-national differences in case fatality ratio. The question to me is, will we see similar gradients in age, in long-term morbidity, in post-acute care needs, in rehabilitation needs? And I'll take two perspectives. One is government policy innovations and interventions that government needs to lead, and those where we, in a major way, need to rely on everybody, you, I, and everybody else, to participate for the post-lockdown, post-acute care needs agenda and policy going forward. One innovation where I'm currently sitting in Heidelberg, Germany, have been Corona taxis. And these are all innovations that I will show that are, if you will, acute innovations. And I think they hold major promise for the post-acute care agenda. And here's an example, the Corona taxis that the University of Heidelberg implemented, that is responsible here regionally in several German states for the COVID response. And they've been staffed by medical students, many of our students by nurse assistants, so by relatively low level of educational attainment healthcare workers, and they've been very good in following up in-home isolation patients. And now I think a question is, will they be equally powerful and useful, desirable and technically feasible, and financially viable in the longer term for post-acute care needs? And my second example, it was terrific to hear from our colleagues in Wuhan. I lived in Wuhan for 2 years in the 1990s and worked as a young medical resident at Tungji Ikedashi, and thus still have a heart in Wuhan. And one of the, of course, powerful policy innovations that Wuhan has given to us is Fangzang shelter hospitals. And here you see a picture of one of those, which allowed Wuhan to very rapidly scale up basic care hospitalization capacity. And I think they are an important policy innovation, of course, building and extending traditional public health approaches, such as emergency shelter hospitals and isolation wards in hospitals, but really with a substantial innovation in integrating them in a very powerful way. And here you see what Wuhan did in a very rapid time. You see the shelter hospitals and the bed capacity of those. And again, my question is, can this novel concept, this public health innovation, be leveraged for post-acute care and rehabilitation needs? Clearly, it was successful as part of the initial COVID-19 control in Wuhan. And here you see the bed capacity going up over time, reaching almost 15,000. You see above the x-axis the number of patients in the hospital going up, almost reaching capacity, and then petering out. As you know, these hospitals have been closed, but of course the facilities still exist. And the powerful idea here is that these facilities exist nearly everywhere. Where we work in Africa, there's hardly any African city that doesn't have a football stadium. When we are in Brazil, there are football stadia nearly everywhere, and other exhibition centers, other public facilities that are currently lying idle. There is capacity that could be leveraged for large-scale treatment needs, potentially including post-acute care needs. Now in China, the Fangzhang Shelter Hospital innovation was for acute care and fulfilled 5 different functions and had, as we identify, 3 major characteristics. I do think we should consider for post-acute care patients coming from hospitals if there are second wave epidemics. Clearly, this is a spillover facility that holds promise for large-scale basic medical care, social care, rehabilitation care in situations where other facilities that exist in the healthcare system are not coping and capacity is massively exceeded. These are spillover facilities. And I do think countries would be wise to prepare for second wave epidemics, for flare-up epidemics, and know where such, if you will, collective facility isolation would be possible, but also collective post-acute care needs if, again, we are getting in some communities, including in Africa, where most of our work is, where health systems capacity could be severely overextended. Another really important question to me is, do we already know who is suffering from post-acute care needs and needs support in the long run? Anecdotally, and I'm sure in this panel there is much more acute clinical knowledge emerging about who is suffering the long-term consequences of a COVID infection. But do we know if people who are mildly infected, and we typically don't see in the health system, do not also suffer major long-term consequences of COVID? So I do think when we are embarking now on these public health intervention studies about who was infected and who was asymptomatic, mildly and moderately symptomatic, we should also learn about what about now, maybe weeks and months after the infection. So in these population representative survey and screening approach studies, I think we will learn powerfully at a population representative level about post-acute care needs. And here's an example from a paper that we are about to publish in the bulletin of WHO, where we run in modeling studies different targeted screening approaches against each other to see how we can save resources to make routine surveillance in entire populations in the long run financially viable and technically feasible. And the same, and I think these approaches can be leveraged for population representative data on post-acute care needs. We've also just won, as you may know, in the European Union, the Horizon 2020 program, the world's largest funding stream for research, in the new iteration to the tune of 100 billion euros per 7 years. there has been a major funding stream on emergency COVID funding, and we've just won one of these Horizon 2020 grants in collaboration with the EDCDP, the European Developing Country Trials Partnership, to work on novel screening approaches that will make long-term COVID control responses, but also long-term care feasible in Kenya and in South Africa, in a collaboration with Aga Khan University in Kenya, Burnett Institute in Australia, and the University of the Witwatersrand in South Africa. Clearly, we will not see the majority of patients with mild and moderate symptoms in the health system in Kenya and South Africa. So population-based approaches through homes and through houses and in huts will be powerful and important. And finally, the government is one side of the coin. The population is the more important second side. And here we've been working on video interventions. Can we do the hard task? The easy task is to motivate behavior change in an emergency situation, in a lockdown. Extreme measures are possible for a few weeks, but they are hard to sustain in the longer term. And now we are in the situation of having to sustain new forms of living together, of social interactions, and we have to develop them, but also to maintain motivation, behavioral intent, and behaviors in the long term. And in that, I think, is also an agenda about detecting long-term care needs and working together, living across generations in homes. How do we better care for post-acute care, elderly adults, for instance? Here's an example from a video intervention study in collaboration with Maya Adam at Stanford, who produces these wonderful, wordless and theoretically universally across cultures, useful videos. And we see here in a few days across major platforms, YouTube, Instagram, Facebook, and so on, we gain 1.2 million views just in a few days, providing COVID-related information. We are doing these studies as trials. We had to close many field studies, and that is sad, and we lose some scientific value through COVID, but we've also gained a new field of scientific endeavor, the virtual field of online trials. And here is the protocol paper for one of these COVID-19 trials. And we're currently embarking on the post-lockdown, post-acute COVID-19 behavioral motivation through entertainment and education videos agenda. And here's a picture that is suggestive of this agenda from one of Maya's outstanding wordless and universally useful entertainment and education videos. So in sum, I think the acute COVID phase has given us powerful policy and innovation approaches that are potentially useful for the long term, and we can learn from them and potentially leverage them. And the four examples I've given are the Corona taxis in Germany, the Fangzang-shelter hospitals in China, alternative screening approaches for post-acute care needs in Kenya and South Africa, and entertainment and education videos worldwide. Thank you, and I look forward to our panel discussion just now.
Thank you, Theo. Let's move to our last speaker, Professor Knapp from LSE.
Okay, good afternoon. Good morning, good evening, where you are. So I'm going to talk briefly. We're very well behind time, so I'm going to try and speed up. I'm going to talk briefly about challenges and lessons learned in the European context. I'm going to speak mainly from a UK experience point of view, but reflect from other countries. I'm going to focus a bit more on the policy context than perhaps the treatment side, which we've heard a lot about this afternoon. Firstly, to say that Europe is very diverse. It's impossible to generalize across the European continent as a whole, but I think there are some interesting lessons that we can pick up, including some common lessons from across those countries, and the two previous speakers have been suggesting some of that as well. So the next slide, please. Can you go back a slide, please? Can you go back a slide, please? Yeah, thank you. So Can you just go to the next slide, please? Okay, let me just talk anyway. So firstly, let's look at healthcare. What we need to think about in relation to healthcare are a number of lessons, and I pulled out 3 or 4 there that I'm just going to say something very briefly about. The first one is that universal health coverage works. Universal health coverage definitely makes it easier to coordinate, to plan, to respond to COVID. But the challenge I think we're seeing in a number of European countries, and we've heard a suggestion of this already, is that politics can interfere. So universal health coverage is good, but it is prone to perhaps political interference in a way which isn't always helpful. Second thing we need to pay attention to, I think, in the sort of post-acute COVID world is to address the inequalities. And what we've seen very clearly across all countries that I'm familiar with is these very marked inequalities. People from lower socioeconomic groups suffer most. People from Black and minority ethnic communities in the UK are having much higher rates of infection and death. Older people, we've heard from previous speakers, are particularly at risk. People with cognitive challenges, whether it's dementia or intellectual disability, also at risk. So inequality is clearly something that needs to be addressed. Even within a universal healthcare system, it doesn't always deal with those inequalities. My third bullet is about the meaning of efficiency. And I think what we've tended to see in healthcare systems across the Western world at least, is a tendency to focus mainly on the sort of treatment definition of efficiency. So how effective is this intervention and what is the cost of achieving it? And I think what the COVID pandemic has revealed is we need to think more broadly about efficiency, thinking about public health prevention in that sense, thinking about the achievement of well-being, thinking about procurement and management capacity and so on. So managing efficiency is a third thing we need to pay attention to. And then I put down there mental health, and at least 2 of the previous speakers have mentioned the mental health consequences of COVID. What we're seeing already is this growing level of mental health problems, both from people who are infected with COVID, but from many other people in the population because of lockdown, because of isolation, because of the trauma and so on. And I think what we're seeing there is a huge wave of mental health problems that are going to be keeping us going for a long time. I'll skip to the last bullet there. What we've seen as well from COVID, it's still very much a human service. That is, we need, although we've seen some previous presenters talk about robotics and telemedicine and so on, and there's definitely scope for using those approaches to treating people much more than we do at the moment. But at the moment, at least, this is still very much a human service, and that puts people who are in the front line of delivering the service at much higher risk of infection and of mortality. Next slide, please. So as well as the healthcare side, I think we need to think about the social care side, or what in many countries is called long-term care. And again, a couple of speakers have talked about this already. What I just want to say first of all is that social care and healthcare systems, I put contiguous, they're next to each other, but they're rarely coordinated. And so what we're seeing in some countries, certainly in the UK, was the attempt to manage the demand, the need for acute care led to very adverse consequences for other systems. And Vincent Mor and others have talked about the nursing home system and how that has been impacted very negatively in this COVID crisis. So we need to think about that. I'll come back to other systems in a moment. The second social care issue I want to mention is around isolation. Isolation of people who perhaps do not have COVID, or at least are not recognized as having the virus, but are isolated within lockdown policies, and that is leading to all sorts of concerns about their health and well-being. And we're seeing a big rise in loneliness, which can lead to all sorts of mental health issues, to suicide in a few extreme cases, and other poor health consequences. The third point there is about unpaid care, usually by family members, but often by friends, or in other times, people in the community. Unpaid care, or unpaid carers, are the front line of social care. They are the people that provide most of the social care to our populations across the world. And of course, lockdown arrangements and fear about infection are putting those individuals under huge pressure and making it very difficult for many of them to deliver the support that they would like to. I've then put down safeguarding as an issue, which is now beginning to cause some worries in many countries. Worries about people because of lockdown who are at much higher risk of domestic abuse, of sexual abuse, children who have been neglected or abused. I think when lockdown finishes in many countries and we return to some sort of normality, we're going to see some real major concerns. And then finally, I put on that slide about institutions. I think what COVID is making us do is to think about the congregate care, group care settings, and how suitable they are for some people. Congregate care settings have been, much higher risks of infection and death for reasons we've heard already this afternoon. We need to think about what the role of institutions within our health and care systems. Next slide, please. So what I put on this slide when it comes up is a whole range of other systems. What we've got here, our health and social care system, I think we have to remember that COVID and similar pandemics are health issues, but they're actually whole society, whole economy issues. And so if we have a policy for COVID, it needs to be clearly centered around the healthcare response and indeed around prevention and so on. But that policy framework needs to cover all of these different areas and many others that are not on that slide. So that leads to these discussions we're seeing in many countries about how to balance the achievement of better health and protection of the health of the population with the need to restart the economy, to restart normal social interactions. And that's a tension which is playing out in different ways in different countries, with many countries thinking they're coming out of lockdown too early and so on. Second bullet there is about innovation, and previous speakers have talked about a number of innovations which are happening very impressively across many systems, healthcare particularly, but also in some of those other areas. And we need to make sure we learn the lessons and apply those innovations and the lessons from those innovations, not just in response to future pandemics, but more generally within our health and care systems. And then finally, up on there, we need to stockpile robust evidence, if we use a verb that's used a lot at the moment, stockpiling. We're seeing very impressive delivery of evidence from researchers, and we've heard some very good examples of that this afternoon. What we need to do is make sure we've got that evidence ready to respond to either the next wave of COVID or the next pandemic or some other similar event. And I think what's been very good to see is how the research community has been very flexible and adaptable and speedy in responding by delivering evidence. Next slide, please. What I want to then reflect on just briefly to finish, David Grabowski said, we're far from out of the woods. I was going to say, are we seeing light at the end of the tunnel? I'm not sure. I think we are seeing some better situations developing, at least in high income countries of the world, but clearly in many other parts of the world, we're still seeing a lot of problems emerging. We need to then learn from these experiences, and it's been a privilege, thank you very much, to participate this afternoon. I look forward to the discussion in a moment. So thank you very much.
Thank you, Professor Knapp. Next, I will move to Adelina. Adelina is going to facilitate the discussion. Adelina?
Thank you very much. And I think it's now my turn to moderate the discussion. We are running late, so I think we're going to have only about 10 minutes for that. I didn't introduce myself at the beginning. I just realized my name is Adelina Comas-Herrera from the London School of Economics. And on the 20th of March, I started what was then a blog called LDC COVID, where we've been trying to gather evidence on what was happening internationally on relation to long-term care and COVID. I now work with Martin, by the way, and I've worked with him for many years. So after this wonderful overview, we have a short time, so I'm going to be quite focused on just a very small number of questions. The first one I'd like to ask was on rehabilitation. And I was thinking, as I was hearing about the difficulties of both delivering rehabilitation in the context of COVID and the risk and the safety and all the complications of considering the risks and the isolation. And I was wondering that maybe a big part of this is also to do with trying to get a better understanding of the long-term value of delivering rehabilitation at the time of post-COVID because of all the new complications that COVID has brought. And I was wondering as well, I think it was Dr. Feng who mentioned that the complication is, or sorry, no, Dr. Wang who mentioned the complication linked to the financing of rehabilitation. And I was wondering if perhaps one of you from the first part of the panel, perhaps Dr. Wang, would like to talk a bit about the long-term value of delivering rehabilitation.
Can I just make my consideration about your question? I'm Dr. Li from Nanjing Medical University. Talking about the post-COVID-19 rehabilitation, I think it is critical to consider the discharge from hospital is not the end of medicine.
I cannot hear the answer.
You cannot hear?
I can hear.
Is my voice clear enough?
I can hear.
I can hear.
Something wrong with our modulator.
We can hear you.
We can hear. You can continue.
We can hear. You can continue.
Okay. Okay. The key is we have to realize the discharge from hospital is not the end of medicine. It's not the end of medical care for the patients with COVID-19, because a lot of patients still got dysfunctions from the from all part of our organs. It's not only from the respiratory function, but also cardiac function, kidney function, and you know, fragile, for instance, weakness is very common. So I think it is critical. We have to consider post-COVID rehabilitation. But in terms of rehabilitation, we are focusing on functioning, which means once the patient return to their normal life, it's a sort of functioning. The access for rehab is very simple, and for rehab is just like aerobic training. It's walking, jogging, and a lot of in China we have a sort of square dancing. It's like also like dancing in Western society. I think this could be very simple way to do it. It does not require any sophisticated equipment. So I believe the key is that our clinicians has got a sense of rehab. Our government has got a sense of rehab. It would be better to have funding support from insurance company. However, if there's no financial support, we'll still be able to use some very simple approach to encourage our patients to do some home-based exercises. So exercise is a really fundamental approach for the post-COVID rehabilitation. This is my point.
Thank you very much. And then a linked point on financing are all the additional costs that, especially now going back to the long-term care, skilled nursing facilities, all the additional costs of providing care at the time of COVID, and the issue of how we finance those. So now I'm going to move on to the US speakers, and I was wondering if one of you would like to reflect a little bit about the current limitations of the way in which long-term care is financed and how that is allowing to meet the additional costs of COVID, be it the cost of PPE, being the additional costs of staff, and the cost of medicalizing care to a large extent. Would one of you like to comment on this?
David,
Sure.
That's your game.
Yeah, David, you should do that.
I'd be happy to comment. Thanks, Adelina. So in the US, we have this distinction, and Joe Ouslander did a nice job of laying it out in his presentation, and that take, for example, a nursing home. They're both caring for these long stay residents, but also these post-acute patients. And most of the revenue, the profits in the United States comes from those short stay rehab patients. those have largely stopped right now in the US. So because we're not doing elective hospital procedures, there's no hip replacements happening, there's no post-acute patients coming to nursing homes. So it's all long stay residents, many of whom are covered by Medicaid. That's not a very generous payer in the US. And so nursing homes do not have a lot of resources. Some states have added some additional dollars to their Medicaid rates, but it's not enough. Other states have put dollars into these specialized COVID facilities, like Vince's home state of Rhode Island is offering $500,000, $600,000 to two different facilities to really kind of give them the capacity and capability to do this care. But I think going forward, we're going to need a lot more support here. And Adelina, to your point, PPE, testing, those additional dollars for workers through hazard pay and paid sick leave, all of that, that's going to need to come out of the federal government. And so we need to see additional spending there. Thanks.
So Adelina, this is Vince, just one little addition to that, and this relates to Dr. Knapp's perspective as well. Universal healthcare insurance or universal health is really, really important, but most of our countries have essentially adopted largely an efficiency transaction-based approach to healthcare financing. So that leaves little space nor incentive for residual capacity for responsiveness to emergencies. And all of us have experienced that, from Northern Italy to the Netherlands to the US, hugely. And how do you then pay for that? In China, there's a tradition of, when there's an emergency, the government comes in and pays for everything lock, stock, and barrel, and just assumes that that's going to be an extraordinary cost. In our world, we're still trying to figure out who's paying for what, how it's being paid for, and people worrying every day about, is this a cost that's covered or not covered? Who's going to pay for this test or who's not going to pay for this test? And that argument puts delays on real action. It's important.
Thank you. I'd like to then move a little bit to a question that's been emerging. So in the work we've done in LTC COVID, we've been looking at country reports and emerging evidence now from any part of the world. And one big distinction we can see in terms of policies is whether to isolate people with COVID or with suspected COVID in care homes, or whether to move them out to a quarantine facility outside. And we see a big Asia, Europe, North American divide. So as far, and perhaps though the situation may be a bit different in Germany. So I'd be very happy to hear a bit more about the German approach. But I'd just like to throw this question and consider to what extent is the policy of isolating within care homes, within skilled nursing facilities, or however you call them, which actually they will vary a lot in their capability, in the fabric of the buildings, and in the training in terms of infection prevention control of the staff. And I'd be very interested to hear then go back to a perspective from China about how infections in nursing homes or care homes have been dealt. Do I understand correctly that people would have been moved to a quarantine facility in that case? Is that maybe Professor Jianan Li?
You want to ask me? I'm actually working for the general hospital, not for the nursing home, the
okay.
facility. However, I would like to respond to your question, because in China, it's just as the previous speaker mentioned, the government pays everything for this COVID-19 cost. But still, we consider two approaches for the post-COVID rehab. The one, I think the best way is to let patients to do the rehab at home. It's sort of home-based rehab. So this is a sort of quarantine at home. It's the cheapest way to do it. And the second way, if for some severe cases with severe disabilities and who cannot do the rehab at home, then China set up a specialized rehab hospital for COVID-19, or I should say rehab facilities could be very small. It's not as big as a hospital, could be very small, but it's specialized with quarantine for that facility. I think it will be two basic approaches for the in China for the COVID-19 post after discharge.
Thank you. And I was wondering, so we could hear from the German perspective from Professor Till Bärnighausen. And what's about because I understand in Germany you have an infrastructure of rehabilitation and hospitals and intermediate care. I was wondering what's the role that they've played, for example, in terms of
yeah, I mean, the real research evidence is outstanding. So we will learn why it worked relatively well in Germany. We've had many infected people and low mortality rates. And one explanation, and I think there's some initial plausibility, but we don't have the research evidence yet, is that precisely those facilities are very well run and looked after and managed at the local level. And I think one really large emerging policy lesson could be that actually decentralized healthcare systems can be rapid and good in their responses to emergencies. It wouldn't seem that way, but the local response means people have local knowledge, and it differs by state, as you know, in Germany to some extent. And that seems to have been a part of the success story, but there are other explanations. So why is there not the mass dying in Germany that we've seen in other European contexts in nursing homes? And another less favorable explanation may be that old people in Germany are not as well connected than maybe in other contexts to their families anymore, and they're more isolated already. And thus the epidemic doesn't spread as much into these extremely vulnerable populations. On the nursing side, just to reflect another model, right? So Germany has in its long-term insurance systems introduced in 1992, which was powerful here, I think, also in the on the financing side, a long-term care need insurance. So people have this insurance as a social entitlement and right through their paycheck contributions into the social insurance system. It was the most recent addition to the German social insurance system, which of course started in 1882 with the Bismarck social health insurance, which is another way to achieve universal coverage, more guaranteed, because it is not the state who is governing that money. It is parastatal institutions who govern it in a negotiated arrangement between providers and insurance intermediaries. And the long-term insurance is the latest addition, 100 years after Bismarck, and it has worked. I must admit, to my surprise, it has worked very well in guaranteeing that people who are frail, who need long-term nursing care, that these costs are borne by the so-called Solidaritätsgemeinschaft, by the solidarity community that everybody contributes throughout their lives, through paycheck deductions too. And as far as I know, this has been sufficient for financing the long-term COVID care needs.
Thank you very much. I'm afraid we are now out of time. It's been a fascinating afternoon for me, morning, night for you. And I think I hope we will continue this dialogue, and we'll continue to learn from each other as we address what looks like will be with us for a while. So thank you very much. I wish you all a good rest of the day, a good night, or a good afternoon. And thanks again. Bye.
Thank you, Adelina. And then I will move. 我下面会邀请这个泰康保险集团的刘挺军总裁给我们这一个讨论做一个总结。刘总裁呢，也是我们泰康全中国在医疗养老领域的专家，也是在武汉大学和中国的这个民政部作为专家委员。那请刘总裁给我们。
Is an expert from the Wuhan University, and he also serves as a professor at the Ministry of Civil Affairs. Good morning, good afternoon, and good evening. It's really an honor for me to participate in today's session. I'm really honored for all of you to participate in today's sessions of the Global COVID-19 Rehabilitation webinar. All of you has a quite exciting speech, although the COVID-19 is triggering or creating a lot of mortality ratio, and it is also being controlled by many different countries and regions. But currently, with 3.5 million people discharged from the hospital, a lot of the patient needs the rehabilitations. Experts from China, Europe, and America is going to be inspiring each other in tonight's session. We have noticed that in the Chinese general public policies perspective, China's treatment of COVID-19 and China's national support of the COVID-19 and China's early interventions of COVID-19 has successfully controlled the COVID-19. And here I want to share with you one important weapons against COVID-19. That is the effort from the all works of life. Just as under the Taikang Insurance Group, we have the Taikang Wuhan Hospital. We were planning to open that hospital in March 2020, but after the outbreak of the COVID-19, we have reformed itself as an infectious disease hospital, saving over 26,000 patients. And we have also noticed that the makeshift hospital in Wuhan is being sponsored by many entrepreneurs and private sectors company. So that is a huge motivation for all walks of life in China. In Europe and in America, we have also learned several different lessons, including the outbreak of the nursing homes. As some of the experts mentioned, the COVID-19 outbreak in the nursing home is just like a box full of matches. It is really easy to be burned. And I think that we should set up a special area for the COVID-19 patient. And we should use the telegraphic methods to reduce the outbreak of COVID-19. I think this is some of the lessons needs to be learned in China. Taikang is the fourth insurance group, largest insurance group in China. Apart from the traditional insurance business, we also have the largest nursing hospitals and nursing homes in China. This COVID-19 outbreak is also generating a lot of challenges for us. We have over 3,000 elderly people living in our nursing center. Back in January, we have adopted a very strict measures to isolate and shut down the nursing homes, and we allowed no visitors for them. But for the long-term separation, isolation measures might trigger many different mental problems for many different patients, many different elderly people. And it is also concerning about the chronic drug usage, and it is also generating a lot of the questions, and I learned a lot from the Europeans' experience and Americans' experience. I think this is also going to provide us a lot of indications as the COVID-19 going forward. With the second wave, which is also going to attack the China, this is also very inspiring. So thank you very much for all of you. We are looking forward to talk to you in the future. The reason for Taikang to set up this public health foundation is that we understand the infectious disease is going to come back within 3 to 5 years. The COVID-19 outbreak is far from distinguishing, so there is also a high possibility for the second outbreak of the COVID-19. Setting up this foundation together with all of you is also going to help us to understand the governance of the government, companies, and also the public, and also as a nursing home practitioner, I believe that this is a very good thing that we could learn from each other, and it is also very good for us to fulfill our mission. We are looking forward to collaborate with you. Finally, I thank you again for attending today's seminar. We are looking forward to the distinguish of the COVID-19 outbreak, and we are looking forward for all sectors of the society to go back to the normal order. Thank you. Thank you very much. That concludes today's webinar.